Okay, so what is the VVED? We are a statewide service that's been operating since 2022 as a full statewide service to see patients within Victoria who have what we call non-life-threatening emergencies. We'll always escalate anything deemed life-threatening through to 000 or emergency departments. So all of our consults occur via video. We use Health Direct to drive those video consults. We are open 24 hours a day, 7 days a week. We have a broad spectrum of medical and nursing specialties that work for our service to make sure that the patient's needs are being met appropriately based off the severity of their incoming complaints. For patients that require interpreter support, we've also got on-demand interpreters that can be called in at the point of registration. I think they can pick up languages in, I think, over 200 different languages at the moment. So that does add some weight to make sure we can pull in the appropriate interpreter, but it's fantastic from a health equity perspective. So I think today, what I mentioned before, we have a broad range of services available, but today's focus is a bit more in the aged care space. I had extended the invitation to Pavinder, who's our aged care lead, but I'm not sure if he's actually available. He might be on shift, but that's okay. We can do our best without him. So we have a JEDI team. So that's Geriatric Emergency Department Intervention is what we call our aged care team, and they provide the service specifically to aged care residents that are directly referred into VVED. That team is made up of emergency physicians, emergency doctors, geriatricians, and sometimes nurse practitioners as well. And so their goal is really to provide that targeted support for elderly aged care patients that present with often those higher level complexity conditions. And especially once we get in sort of palliative care space as well, and we do plenty of that. So from a benefits perspective for the patient and facility, our goal is to help keep these patients healthy or well in place and prevent that unnecessary transfer or movement, because we see the amount of sort of negative outcomes from patients with the hospital-acquired infections and injuries through the transfer process. When we can actually keep them well at home, provide them with interim medication, and then reconnect them in with their service GP where possible in the future, or if need be, we can admit them into one of our sort of variations to a short stay unit here called our virtual observation ward, or then subsequently link them into Cassie's service as well for some additional specialist care. But Cassie can talk to that in some more detail later. Just broadly in terms of some utilisation of VVED, you can see across the last 12 months, we've still been steadily growing. I had a meeting this morning with another region showing that we had about within the Hume region, we had 400 registrations in 2023. Compared to last financial year, we had over 3,000 registrations. And you can see that growth continues, and we maintain that great level of outcome in terms of what we call diversion, and that's just keeping patients out of emergency departments, either through AV transfer or otherwise. This is something, and apologies, it's a little bit grainy, but this is something that was developed in collaboration with Ambulance Victoria in terms of helping to determine what service support you should seek based off the severity of the patient's complaint. So for those low to medium acuity conditions, we recommend as a starting point to reach out to the facility or the patient's GP. Can they provide help? If they're unavailable, is there any Resi InReach locally available? And I'm aware that those services can be disparate. Often these clinical deteriorations occur after hours as well. And so then as that third point of escalation come through to VVED, complete our registration, see one of our team members to get that interim support and carry over. Obviously for those high acuity conditions, always go through to AV. 000, those patients can also be seen through a paramedic pathway. So if those paramedics arrive on scene, they can contact VVED directly themselves to just sense check before they need to transfer if they don't think it's entirely appropriate. And I always like to link back into the palliative care advice service as well to make sure that that's aware, and people here are nodding so you all know about it, but that's okay. We've got a couple of case examples here, which I think are just good to showcase the purpose and the utilization of VVED and the value to the patient. So in this case, we had a patient who was found on the bedroom floor. A fall with a head strike unwitnessed is a very common presentation within VVED. The doctor is then able to assess the patient, determine, what medications are on and is there any additional risk based off that. They brought in the family members to the consult as well, and that's something really important to us, is ensuring that the medical treatment decision makers are involved in any of the decisions as part of the consult. We'll also try and pull in the GP if they're available, but noting that a lot of these occur after hours, and like everyone, GPs like to have a bit of non-work time in their lives. They're also looped in after the consult as well with any notes. So in this case, the decision was made to loop this patient in with residential inreach, and then to continually review that plan and re-escalate if further deterioration occurs. A similar case here was not similar, but an acute stroke case here with a 96-year-old. The advanced care directive was then reviewed by the clinician during the consult, and stating that their transfer needs were specific in terms of when to move them to an ED. As part of that consult and assessing the additional information provided by both the facility and the medical treatment decision maker, the decision was made to palliate that patient at home at their residence with a GP follow-up the next day. So medication was prescribed to maintain that level of comfort for the patient until the GP could arrive the next day, and then also further directed to contact Resi InReach or palliative care advice or VVD ultimately if additional support is required or if the patient condition changes. And that's something that's really important here, is to remind everyone that you can come through to us multiple times. There's no limit. We hope that we can meet the needs of the patient in a single episode, but patient conditions, especially in aged care, do change quite rapidly. Sometimes it could be over the course of hours, it can be in the course of minutes post a consult. So if you need to call back, you can always do so, and we'll try and loop you back in with the same clinician where possible to maintain that continuity. But sometimes that's not always the case. But our notes are always there. As I've mentioned, there's a couple of different pathways where you can access VVED. So we have the direct pathway from aged care into VVED, or from our GPs, and these all fall into our healthcare professional pathway. There's also a self-registration pathway for patients at home. So for all of these pathways, the endpoint for those is directly into one of our doctor wait rooms, because the expectation is that on scene, clinical triage has already occurred to determine that medical intervention is required. So how do you access our service? We've got a publicly accessible website, vved.org.au. We've got a few tiles on our page. So one of them obviously for aged care. Are you an aged care service? You click on that, it'll take you straight into our registration form. Once you complete that form, you'll then be directly moved into our Health Direct room, where you'll just wait to then be seen by one of our doctors. Sometimes that wait can be a little bit long, and we're working on some processes and procedures to enable the local staff to not have to sit and wait with the patient for sometimes, especially for lower acuity conditions. Those waits can be over an hour, and so sometimes sitting there whilst you've got other residents or patients that need help as well, it can be a little bit daunting and frustrating. So we're trying to work out a way to release that local staff and then send a notification to say the doctor is ready to see you, so please jump back onto the call. I'll hand over to Cassie to talk about VSC.
Thanks, Richard. Hi, everyone. I've just realised, looking at these slides, that I was so focused on updating it with our new name and less on the content today, so apologies. So we have just rebranded to Virtual Specialist Consults from VVSC. And we originally had that name to align with VVED, but we've grown so much now. We are slightly rebranding to ensure that we can showcase what we can do. So the idea originated for VVSC back in 2023, and it came from one of our gen med physicians who, in his triaging of a lot of referrals, noticed that a lot of referrals could have been dealt with through a phone call, basically like the phone a friend sort of setup that people use informally. What we find are a lot of people will, a lot of GPs or nurses in the community, they'll call the hospital wanting to speak to, say, a haematologist, and end up getting passed through to different divisions, or may end up speaking to a junior medical officer that perhaps doesn't adequately answer the question. So what we thought is we would formalise it and give our community-based clinicians an opportunity to pick the brain of a hospital-based physician and just have that full attention for 20 minutes. So we set up VVSC. And it was an opportunity to help tackle some of those long waiting lists, and also some of those piecemeal referrals that come through to the hospital. Thank you. So we provide basically access to hospital-based specialists. So the top one is our co-consult. So the GP can attend an appointment. They can schedule a 20-minute appointment with or without their patient present, and speak to one of our specialists in the hospital to discuss one or multiple cases when they're considering an outpatient referral. We've also branched out due to demand from across the state, and we're providing dedicated clinics where, whether it's health services or really regional remote GP clinics, they will have a selection of patients that are waiting to see, an example, a paediatrician, and you know, the commute is maybe 3+ hours. So we provide them with a dedicated clinic for a pediatrics, and they're able to see the patients for them and help the GPs manage their care. We've also started offering direct referrals for regional and remote health services, or GPs, to be able to directly refer in. Our physicians comfortably see those patients for a couple of consults and then refer back to the GP. Ideally, the GP dials in with the patient, which then reverts back to one of those co-consults. But we find that sometimes patients are pushing for a specialist outpatient referral when in actual fact the GP is managing the case appropriately, and it's not always required. Sometimes the GPs, when they are isolated in some of those regional areas, they dial in and it's almost just checking they're on the right track, and generally we find they are on the right track. Richard? So some initial analysis of our referrals that came in. We've found that before VVSC, a lot of GPs and nurses were planning an outpatient referral, or they had actually booked one. And then after a co-consult or a case conference, a lot of them had actually been resolved. Oh, sorry. A bit distracting. And therefore, very few actually required a referral to outpatients, or they, in some cases they were, but it was a bit clearer as to what to put on the referral, or what tests should be ordered before the referral into the outpatient clinic. Richard? Thank you. So here's an overview. I'm very aware of the target audience. So here's a list of all of our specialties available. You'll see we have quite a few which perhaps would appeal to this cohort. We have advanced care planning. We have a wound consultant as well, and we actually get quite a few nurses from RACFs dialing in to consult with our wound consultant. It's the same sort of thing. It's where they just want to check they're on the right track. Have they explored all of the dressings or options that are out there, or perhaps is there something else that could be tried that they may not stock, or that the wound consultant can recommend? We run Jerry clinics, we run Gen Med clinics, and we have, as you can see, quite an offering there for adult services. One of our most popular ones would be psychiatry. So adult psychiatry and older adult psychiatry. what the setup of these clinics run a bit differently. They have to be co-consults. As you can appreciate, our psychiatrists only offer half-an-hour appointments, and so therefore don't really have capacity to be able to do full assessments. They are relying on the GPs to maintain that care. It's more an opportunity to dial in and explore whether or not they've exhausted all of the options out there. Richard. So here are the details. The website's up, and as I said, we are just rebranding. So it is slowly happening. What we've also just commenced as well are asynchronous co-consults. So while we have really streamlined the synchronous, where you can book in and speak to one of our consultants, we have just launched for certain specialties, you can actually just email in a query. So that's our asynchronous model. So only certain specialties are participating in this trial at the moment, but we know it's for more general advice. So if perhaps you're wanting to ask specific questions, we would recommend dialing in for a case conference or a co-consult, but otherwise more general advice that you feel like can be dealt with from an email. You send through a query on the platform, and within 3 working days, business days, you should receive a response from our physician.